Assalamu alaikum. Starting with the holy and merciful name of Allah, I am Dr. Arslan. I am here to present my group I with my Dr. Tahir and Dr. Imran. Today is our patient. So here we will observe the abdominal examination. Abdomen refers to the region between the pelvis and thorax invertebrate, including humans. The space constituting the abdomen is termed as the abdominal cavity. If we see the border of the abdomen, we see anteriorly we have abdominal wall, and posteriorly we have peritoneum. Inferiorly we have pelvic inlet, and if we see superior we have a diaphragm. After the abdomen, we will see here we will divide the abdomen into 4 quadrants and 9 regions. If we see the regions, we have right and left hypochondrial region, right and left lumbar region, right and left iliac region, and we have epigastric region, umbilical region, and hypogastric region. And same we have 4 quadrants. Under abdominal examination, we will start from inspection, then we will go for auscultation, and then we will go for percussion, and then palpation. For general inspection, begin the examination at the end of the bed with an inspection of the patient's general condition and their surrounding. Explain to the patient what you are doing to avoid embarrassment. Starting with the introduction, we will use wipe, means wash your hands, introduce to yourself, identity of patient, age, name, date of birth, permission, pain, position, and start from the hand. From hand we will see clubbing on shape and the color of the nails. We will see palms, and then in the last we will see the duplicate contracture. If we see the color of the nail, if we see the white nail, it indicates that something will be occur with the liver, means hypoalbuminemia. If we see the white nail, it means it's a sign of hypoalbuminemia. Hypoalbumin, basically it is a protein that is synthesized from the liver, which if white nail, it will indicate that liver will not synthesize the albumin, and it will something going wrong with the liver. If we see the shape of the nail, if we see spoon-shaped nail, we call it chylonychia. It will be due to severe iron deficiency anemia. Iron deficiency anemia, basically it may be the patient may be take less intake of iron, or maybe due to loss of iron. Something else will happen with the patient if we see the spoon-shaped nail. Then we see the palm. If we see the palm arrhythmia, mean red palmness, it also indicates that there is something wrong with liver, mean chronic liver disease. On the last, we will see the duplicate contracture. Duplicate contracture means thickening of palm fascia, especially the little and the ring finger. The cause of this is unknown, but it will associated with diabetes, smoking, and alcohol. After the hand, here you will see the chylonychia, means spoon-shaped nail, and leuconychia means white nail. And here is we see the finger clubbing, and duplicate contracture means there is a thickening of fascia between the little finger and the ring finger. After this, after examine the hand, we will go to wrist, arm, and axilla. On the wrist, what will you inspect? What we will see? You will first observe the radial pulse. After radial pulse, you will inspect. You will see the tremor and the astraxis. What is astraxis? Means we will ask the patient to please hold your wrist like this. If you see the jerkiness or flexion on the wrist, it will indicate that something is going wrong with the liver. If a patient hold like this, it will indicate that patient is completely normal. If you see some jerkiness, some flexion on the wrist, it indicates that there is something wrong with the liver. After this, we will go to arms. On arms, what we will see? First, we will observe the blood pressure. Second, we will see the intravenous drug use, means intravenous drug use on the palm. We see some signs of intravenous drug. If some patient use the intravenous drug, we will see the signs on the arms. It will indicate that there is a risk factor for hepatitis. After this, we will see the arteriovenous fistula. Arteriovenous fistula means there is an abnormal connection between the arteries and vein. If we see there is an abnormal connection between artery and vein, it will indicate that there is some renal replacement therapy. What is renal replacement therapy? Basically, renal replacement therapy is that our kidney will not perform well. Basically, the function of kidney is to clean our blood. Here, the kidney will not perform well, so we will use some artificial method like hemodialysis, peritoneal dialysis. Means the patient is going on some artificial method of cleaning of blood like hemodialysis and peritoneal dialysis. So we will see the arteriovenous fistula. On the axilla, what will you see on the axilla? On axilla side, we will inspect the hair loss and we will see the acanthosis nigricans. What is acanthosis nigricans? Means there is a darkening and the thickening of the skin of the axilla. If you see there is a darkening or the thickening of the skin of the axilla, it indicates that there is something wrong with the insulin resistance. Means is that the insulin is there, but it will face some resistance to work. Here we will, if you see that there is resistance in insulin, you will say that it's a type 2 diabetes, because in type 1 diabetes you already know that in type 1 we have no insulin because pancreas will not produce any insulin, but here we see that insulin is there but it will face the resistance. Means pancreas produce insulin but at receptor side it will face some resistance. So it will indicate the type 2 diabetes. After this we will see the hair loss. If we see hair loss on the axilla, it will show that there is some iron deficiency, anemia or malnutrition. Maybe the patient will decrease intake of iron, or maybe iron will not absorb on the GI system. After this, on axilla, after the hair, we will see acanthosis nigricans and radial pulse. After examination of our hand, arm, the axilla, we will go to face. On the face, what we will see? First, we will see the conjunctival pallor for the signs of anemia. After this, we will inspect the eye for yellow color jaundice. If you see the path theory of jaundice, what we have our red blood cells, which approximately the life is 120 days. After 120 days, what happens to our red blood cell? The spleen will engulf our red blood cell. It will convert into heme and globins, as you already know. What will happen to them? Then it will convert into bilirubin. What bilirubin? Unconjugated bilirubin. It will enter into the liver, and liver, after the liver, it will convert into conjugated bilirubin. Then this conjugated bilirubin will enter our GI. From GI, it will excrete from our body. What will happen here? This bilirubin will stay in our body. It will because bilirubin is a yellow pigment. If it stays in our body, it will convert our body color into yellow. So if it will stay in our body, it will convert our eyes color into yellow. Our skin color into yellow. So maybe in this case, the liver will not convert the bilirubin into conjugated bilirubin, or something blockage will occur which will not allow the bilirubin to remove from our body. So here we will see the yellowish of the eye. After this, we will look for xanthelasma. Xanthelasma means there is a yellowish growth on the lid of our eyes. What do you mean by due to deposition of the lipids? Due to deposition of the lipid, which may be occur in the chronic cholestasis. What is chronic cholestasis? Cholestasis means there is a blockage in the movement of bile. What is bile? Bile basically is a protein which is synthesized and released from the liver. After it is stored in the gallbladder. If from gallbladder it will enter into the bile duct, then pancreatic duct, then enter into the duodenum. If something blockage will occur on the passage of this, it will result into xanthelasma. After this, we will go for angular cheilitis. What is angular cheilitis? Angular cheilitis basically is a fungal infection which will see on the border of the mouth, inflammatory lesion on the border of the mouth, the corner of the mouth. It is also due to iron deficiency anemia. After this, we will see some ulceration, and then we will see atrophic glossitis. Then at neck and the chest, we will see lymphadenopathy and virtuous node and tortoise sign. So I will invite Dr. Tahir, please show us how to examine this thing.
First of all, wash hands, then introduce yourself to the patient. I am Tahir, final year medical student. I am here to examine. Can you please tell me your name?
Muhammad Imran,
Your age?
27 years,
Are you married or single?
single.
She has to be.
Thank you.
Today, I have been asked to examine your abdomen. This will involve looking from the end of bed and feeling various areas of your abdomen. Then listen at the end. Would that be okay?
Okay, sir.
Have you any pain anywhere at all?
No, sir.
Have you any questions?
No, sir.
No general inspection. Sir, we can start the exam now, and I am just going to start by having a look from the end of that. Can you please lay down on the desk? From the end of the bed, we look for the body habitus, scars, jaundice, and abdominal distension and muscles. Relax. Now inspect hands. Sir, I would like to start looking at your hands. If you could bring them up in front of you like this. Here we look for Gurinathia and Ligonathia. If you could turn them over like this. Okay, good. Here we look for palmar arrhythmia. Brilliant. Yes. Now for plumbing. Sir, can you bring your fingers together like this? Here we check sacrum's window test, which is lost by the finger. Okay, brilliant. Sir, can you now bring your hand out in front of you like this? Like this. Yes. Good. Here we look for hepatic encephalopathy and uremia, and now inspect for the axilla. Sir, could you just lift up your right arm, please? Here we check for acanthosis nigricans. Now the left arm. Oh, good, brilliant. Now we inspect the eyes. Now Graham, look at your face. Would that be okay?
Okay, sir.
If you just look straight ahead for me, where we look for hyperlipidemia. Sir, now I am pull down your lower eyelid. Is it okay?
Okay, sir.
Here we check conjunctival pallor and anemia. Now just look down for me. Here we check jaundice, raised bilirubin. Inspect the mouth. Can you open your mouth? Can you lift up your tongue on the roof of your mouth? Here we see for the angular stomatitis, oral candidiasis, mouth ulcers, glossitis. Now examine the glands. Now I would like to examine for any glands in the neck. Here we palpate the lymph nodes. Here palpate the lymph node and check for the here palpate for the virtual lymph nodes, left supraclavicular fossa associated with the gastric malignancy. Infection and malignancy are the causes of lymphadenopathy. Now we inspect the chest. I would now like to move closely inspect the chest. Can you please lay down on the table? On the chest, we look for the spinal and gynecomastia. Okay, you can relax.
Thanks, Dr. Tahir. Now we will go to abdominal examination. On abdominal examination, what we will see? First, we see secreting marks, bruising, spider nevi, and gynecomastia. What is skeletal mass is a feature of cholestatic liver disease. We already explained this. After this, we see the bruising. Bruising due to impaired clotting factor production in the liver. Failure means we already know, everyone know that almost all the clotting factors synthesized from the liver, except three clotting factors, 3, 4, and 8. Second, we see the spadonevile. Spadonevile basically is the telangiectatic lesion which will fill from the central feeding vessels. Then will it is due to the excessive production and level of estrogen level. As we know, estrogen is metabolized in the liver. If liver will not metabolize the estrogen, it will accumulate in our body. It will result in the spadonevile. If the estrogen also we know is a sex hormone, if it will accumulate in our body in men, it will cause into gynecomastia. Second, we will see the striae, sinuses and fistula, stromas, and after this we will go to abdominal auscultation, assess the ball sound, normal ball sound, tickling ball sound, and absent ball sound. And aortic varieties and renal varieties. Now I will invite Dr. Tahir, please inspect and auscultate the patient.
Now auscultation. Sir, I just auscultate your tummy for that way. Can you please tell me? Now auscultate the tummy to assess the ball sounds. I just take my patient. The bowel sounds are normal, and aortic growths are normal, and renal artery growths are also normal.
So after inspection, percussion and auscultation, now lastly on abdominal examination we go to palpation. On palpation, what we will see, we will look characteristic abdominal mass, location, size. Then we'll first we'll percussion, abdominal percussion. First we'll percuss the liver, then we'll percussion on the spleen, and percussion the bladder, and assess the shifting dullness. Means the percussion from the umbilical region to the patient left flank. If dullness is noted, this may be suggested that the percussion of ascitic fluid in the flank. Now Dr. Tahir will show us how to percussion the patient.
Now percuss the patient. Sir, I'm not gonna tap on you. That way, can you please tell him? First of all, percuss the liver.
ताहिर इस साइड पे आ जाओ.
Now, I want here pay attention to the change in percussion when I tap on the liver. Here note from the nasal to depth when reaching the liver borders. Here I percuss on the spleen. Now percuss area for the suprapubate bladder urinary retentions. If you suspect ascites, assess for the shifting dullness. Here, wait 30 seconds for percussion and ask patient put your roll onto your right hand side for me. Wait 30 seconds. Then focus. Okay. Yes. Yes. Brilliant.
So after doing inspection, auscultation, percussion, now lastly on abdominal examination we go for palpation. On palpation we check for the characteristic of abdominal mass, location, size, shape, consistency, surface, tenderness, movable or fixed, shifting of perspiration. So palpation ensure that your hands are warm, stand by the patient right side, help the position to the patient, tenderness, rebound tenderness, tenderness plus rigidity, palpable mass and aortic pulsation. First we light palpation, then we go for deep palpation and palpation of aorta. For the palpation of aorta, we will go for abdominal aorta may be palpated in the midline above the umbilicus, particularly in the in thin people it failed. Then we will go for palpate the liver, begin the palpation in the right iliac fossa, starting at the edge of the superior iliac spine using the flat edge of your hand. Then we will go for the palpation of gallbladder, and then we will check the sign, the Murphy sign. Position your finger at the right costal margin in the mid-clavicular line at the liver edge. Ask the patient to take deep breath. If the patient suddenly stops mid-breath due to pain, this suggests that the presence of cholecystitis known as Murphy sign positive. And then we will palpate the spleen. And then we will now the ballot of the kidney. Place your left hand behind the patient back, below the ribs and underneath the right flank. And then lastly we will palpate the bladder, and then we will assess the patient lower legs for evidence of pitting edema, which may suggest hypoalbuminemia, for example in liver cirrhosis, protein losing enteropathy. Now I will invite Dr. Tahir, please show us palpation.
Palpation of the patient. Patient should be into the spine position. Sir, we are going to move on to your more close examine your tummy. For this, I should need you in a flat position. Can you please get on it? First of all, inspect abdomen. Now, just pull down your hands. Inspect the abdomen. We look for scars, masses, distension, pulsation, and stomas. Now, palpation. I like to move on to fill different areas of the tummy. Can I just, before I do that? And you don't have any pain? No. Or, first of all, light pain. Well, we palpate across the 9 regions of the abdomen. Here, during the palpation, note any abdominal garden or masses. First of all, we start from the left iliac fossa in S-shaped manner from the right side. First is a light palpation. Start from the left iliac fossa, then left flank, then left hypochondrium, then epigastrium, then umbilical region, then suprapubic region, then right iliac fossa, right flank, then right hypochondrium. Now, deep palpation. Now I press harder. During the palpation, monitor the face of patient for signs of discomfort. Now palpate the liver. Could you take some deep breath in and out for me? Now balance the both of kidneys. Now, palpation for the abdominal aorta, abdominal aorta aneurysm. Relax.
Thank you. Now Dr. Tahir will summarize the abdominal examination.
I performed an abdominal exam on my patient Imran, 27-year-old male. He has low peripheral stomatitis, stigmata of GIT disease. His abdomen was soft and non-tender with no masses or organomegaly or auscultation. He had normal bowel sounds. This was a normal abdominal exam. To complete the exam, I had like to examine the hernial orifices and also do a digital rectal exam and examination of external genitalia if indicated. My patient is normal. Thank you.